Good morning, everyone. Just giving you a chance to come in. My name is Daniel Singleton. I head up Faith Action. We're pleased to have you all with us today. I don't know how it's been for you, and in terms of Zoom and connections, it's been a bit rusty. So we'll see how we all do. We'll see who gets the prize for the first person to try speaking without their mute turned off. Probably ought to try and provide you with a very special Faith Action mug. So welcome and thank you for all attending. We've got a good number of people coming in, and I can see on my screen attendees are generally gathering in here. So we're going to give people a bit of a chance to arrive. While we're waiting for people to come in, please do complete the poll that should have flashed up in front of you, which should be on your screens. So there's an opportunity for you to give us some information, and it's always good to connect together. We're really delighted to be launching this new resource, Talking Faith in Suicide Prevention. But we're just, as I say, we're just giving people a chance to arrive, and I'll do that circular thing about repeating myself a number of times so we capture people as they come in. And but no, we're pleased you're here, and you're very welcome. We've got a good number of people coming. That's why we're using the webinar format today, which is a bit different. It's been a little while since I used the webinar format myself. So anyway, hope that you're sitting comfortably. If you've done your poll, sorry, if you've got your glass of water or whatever with you, we'll be ready to start any moment now. But we're just giving a few more people a chance to arrive in that sense. Now you can see the Faith Action team have got this delightful beige background that I've got here. See Jeremy's on the call and Peter, and there's a number of other people. Andrew's also around as well. So we've got a great bunch of panelists joining us today, and so we're looking forward to hearing a number of different voices. So if you're just joining us, do welcome. Do have a go at filling out that poll. It gives us an opportunity to collect more information, to reflect a little bit on what we're doing. We really feel this is start of a process, really important discussion. There's been a lot of people that have signed up for this particular event, so we're really interested to see what reflections people will have on this new resource that we're launching today. The resource is called Talking Faith in Suicide Prevention. So we're just going to give a few more minutes for people to arrive, because people are just coming on. I think the internet is humming with a queue. Must be a bit like a bus queue there, people waiting to come on. Appreciate you giving this time, and looking forward to seeing how you receive our publication and what people have shared with us, how we've pulled things together over the past period. While we're waiting, my name's Daniel Singleton. I head up Faith Action, and we have a number of different activities go on. This work has been funded through the VCSE Health and Wellbeing Alliance, which is a commission program from NHS England and the Department of Health and Social Care. So Faith Action has been part of that program under different names. It's changed names at different points, but it's been in existence one way or another since 2009. So we're very pleased to be part of that, effectively to be the government's faith voice on faith and health. We sit alongside other partners such as Race Equality Foundation, Age UK, and others representing different parts of the community. So our angle is faith, and that's really important. And we're really pleased that we were able to talk with the alliance, with the officials that head up that, and agree to do this particular focus on suicide prevention. There's been a fair amount of interest, and we think there's going to be more opportunity going on. I can still see people arriving, so we'll give people a little bit more chance to get here. But as I say, if you are just arriving, please do fill out the poll, and which should flash up on your screen as you arrive. Cool, good. All right, well, just again, sorry for those who've heard this already. Just want to welcome you here to this event. Really pleased to have you here. Do fill out the poll as it arrives. We're really delighted to be launching the new resource, Talking Faith in Suicide Prevention today. We're very grateful for the funding and the support we've received from the VCSE Health and Wellbeing Alliance. And I'd like to hand over to Jeremy Simmons, who will guide us through the resource and introduce what's to happen this morning. Jeremy.
Thank you, Daniel. I'm just sharing my screen for you all now. Great. Hopefully you can all see that okay. Yeah, that's all looking good. Brilliant. Well, thank you, Daniel. And yeah, as already said, really great to be able to launch this resource today and to see so much interest in the work that we've been doing around faith and suicide prevention. I'm really going to begin by setting the scene for the work that we've done before handing over to hear some differing perspectives on this theme of faith and suicide prevention from the perspective of different work streams in that area. I would just like to say, to kick off, due to the nature of what we're discussing this morning, given that we're all coming from very different backgrounds with different lived experiences, some of what we talk about may be difficult or triggering for people. So just a reminder, let's be aware and look after ourselves as we think about these themes. And if you do need any further support or want to talk to someone, we're going to pop some links, general links in the chat, which may be helpful for that. So just to be aware of that. Great. So just a brief overview of the agenda for this morning. As we've already said, I'm going to be kicking off with some background to this work, how we got to this point. We're then going to hear from some colleagues from the Royal Borough of Kensington and Chelsea and Westminster City Council. Very snappy name there, but some engagement work that's been happening across that bi-borough area around faith and suicide prevention, the broader piece of work. So really keen to hear those perspectives. And we're then going to hear from Dr. Imrana Siddiqui, who's a GP, and really giving that perspective of a kind of frontline view of this issue of faith and suicide prevention. We're going to finish by walking through the resource. So I'm going to do my best to sort of navigate us through that and kind of show you what's included and how to find your way. And we're also going to have some time for Q&A as part of all of that. So do use the Q&A function. So you'll see across the bottom of your screen, there should be a little button that says Q&A. If you click that, it allows you to post a question either to myself, to the Faith Action team, or to any of our panelists. And we're not going to answer the questions live, so we won't be typing responses to the questions, but we are going to be collating them. My colleague Peter will be gathering together those questions, and we'll be able to in those Q&A sections pick out a few for us to answer. So do interact with the Q&A and ask any questions that come to mind as we go through. As Daniel already said, all of this work is part of a program called the VCSE Health and Wellbeing Alliance. That's what made this work possible. If you're not familiar with the Health and Wellbeing Alliance, it's a partnership between the voluntary community and social enterprise sector and the health and care system. And it's really about ensuring that decision makers hear the views of communities experiencing inequalities and really bringing, encouraging co-production in the creation of person-centered care. And you can see a number of the organizations that are part of that alliance on your screen at the moment. So we sit on that alliance, as Daniel said, really aiming to bring that faith voice into that policymaking space. It's jointly managed by the Department of Health and Social Care, NHS England, and the UK Health Security Agency. So there's been some really great work that's happened across the alliance this year, and National Voices have collated all of the work that's happened. So do go on their website if you want to find out more about what's been achieved under the Health and Wellbeing Alliance. Really just to kick off then on this theme, our topic for this morning around faith and suicide prevention. Really the work that we've carried out this year has come out of conversations that we initially had with colleagues working in public health across the borough of Royal Borough of Kensington and Chelsea and Westminster City Council. And I won't go into too much detail on that because I know that they're speaking after me and they're going to explain more about their broader programme of work around engaging with seldom heard communities. But some key themes that we picked up in those early conversations and really drawing from their wider engagement work was that really there's a need for greater understanding when it comes to faith and suicide prevention. And this recognition really that faith can play a key protective role when it comes to suicide prevention, being part of a faith community, the support that provides. But also it can present a challenge, especially concerning the stigma that still does exist within many faith communities when talking about suicide. And so almost this dual element of this protective element, this positive element, but also a challenge that comes with it. And so it was clear that there really were a number of pieces of work that needed to be done in exploring this theme further and taking the work forward. On the one hand, there was a piece about upskilling faith communities themselves. So kind of a faith-facing element, upskilling them in terms of how to engage in suicide prevention initiatives, raising awareness about these issues. But alongside that, there was a need to upskill frontline workers really to address faith and belief within holistic conversations. So those people that are actually engaging with the public that may not be people of faith themselves, but may come into contact with people of faith. And the final area was really about addressing the stigma and misunderstanding that may exist within faith communities around suicide through theological engagement. So a kind of deeper, richer piece around engaging with faith specifically and addressing stigma. So there's this awareness of a lot of work that needs to be done. But what we did this year was really focus in on that second line, which is really seeking to improve faith literacy, faith awareness and faith engagement among frontline workers. And so it really led us to this overall aim, which is to develop a resource for frontline workers on the role of faith and belief in suicide prevention conversations. And just a little word about what we mean by frontline worker in this context. So we're really using this term to encompass anybody interacting with patients and public in a professional capacity, who may engage in conversations around suicide prevention. So that's obviously a very broad category, but it could include health professionals within primary care or other settings. It could include allied health professionals or social care. So that might be link workers. It could be pharmacists, other roles. It could include the wider public services or other sectors such as retail, hospitality, or entertainment. And of course, it could also include the voluntary sector, so helplines and statutory helplines as well. So what did we do in terms of our timeline for the work? Well, we began with engagement. So in summer of last year, we started speaking to faith leaders and faith communities about their thoughts and their experiences in this suicide prevention space. It's a new area for us as Faith Action. We've not done any work around suicide prevention before. So we really wanted to learn what was out there, where was their existing expertise, begin to set the parameters for what this work might look like, what the resource would look like, what it would need to include. We held a wider design group with 31 frontline workers, faith leaders, and people with lived experience. Again, really to ask those questions around, what does this resource need to look like? What does the functionality need to be? And what are the kind of themes that we need to include when thinking about faith and suicide prevention? We then moved into drafting. So between September and October of last year, we were really taking what we learned from that engagement and beginning to produce this resource. And again, we wanted this to be a collaborative process. And in the end, 24 people gave detailed feedback on our draft resource. There were lots of emails back and forth and drafts back and forth, and we're really grateful for everybody that contributed to that. And it really was a kind of a challenging process in many ways, kind of drawing in lots of diverse perspectives, but really rewarding and some really rich content that ended up in the resource. And that includes faith leaders, frontline professionals, people with lived experience, all feeding into that final content. And then that obviously brings us to today, which is the launch, which we're really pleased to be at this point and being able to share it all with you. So next, I just want to talk about some things that we learned along this process and just summarizing that a little bit. So I'll talk briefly about what we learned about faith and suicide prevention. And then I'll move on to talk about how the resource, what we learned about how the resource ought to look and should look. So in terms of faith and suicide prevention, the first theme that I want to pick up that we really hit upon is this reality of the complexity of talking about faith and suicide prevention together. And it's this reality that, as we've already identified, as I've already mentioned, when it comes to faith communities, there really are resources that can support prevention, but there are also potentially challenges. And this reality that often within that faith context, the things which might help one person walk through challenges that they might be facing might be a hindrance for another person. And so just really this need for a personalized approach. And just a kind of case study that illustrates that. For one person, a supportive faith community, so thinking about the community nature of faith, the fact that faith communities are quite close-knit, caring communities, that might be exactly what one person needs to help them navigate life's challenges. But for another person, it might prompt thoughts about the stigma surrounding suicide. It might prompt them to withdraw for fear of being exposed. There are a number of quotes and reflections we had from people that picked up on that. So someone said, while the congregation is a really good support network, it can also work as a detriment. People do try to be helpful, but they feel they need to say something or fix it. Someone else said, faith communities tend to be quite tight-knit communities. So I think that in that sense, people tend to withdraw out of fear of being someone's afternoon tea gossip. So again, this kind of dual element of things that can help, but also things that can present challenges. The second theme that really came out was this theme of impact. And this is really the recognition that if faith is a part of someone's past or current lived experience, it will more likely than not impact the way they view the world. It will affect the lens through which they view the world, and also how they might feel about or deal with suicidal thoughts. And just this need for professionals and other frontline workers to consider that reality within holistic conversations that they might be having with people. The reality that ignoring faith or leaving faith out because it might be a difficult topic to address, it's not going to change the fact that that's the way people view the world. And just a quote there that illustrates this: there are people that do seek professional help, but they still want to understand what is happening to them. Is it based on karma? They've got so many questions they want answering based from their faith. And it's not that every frontline professional can answer those questions, but it's that acknowledgement that faith might be a part of their journey. And so that really leads us to the final point, which is this point about listening. So the conclusion being, rather than ignore faith or leave faith out of these conversations, it's better to lean in and to listen and really see some of the challenges and the resources that are inherent in faith communities as an invitation to take a personalized approach to these conversations and really listening and hearing what matters to people. And just a really powerful quote that has stayed with us is this idea of moving away from trying to be culturally competent, where you have to learn everything about someone's faith, and instead taking the lens that the person is the expert, practicing cultural humility and learning what faith means to them, not in a pressured way, but just in that sense of being ready to listen, being ready to hear what might be informing the way that they view the world. So finally, what did we learn about how the resource should look? So the first thing was that it needed a really clear remit and audience. There was this reflection that, you know, a resource that's addressing kind of crisis management is going to be very different to a wider resource around prevention. So that need to really clarify the remit. We heard that really, given the target audience, we wanted a resource that's quite easy and quick to navigate. Again, recognizing that often people working on that front line can be quite time poor. They need something that that they can dip into and find the information that they need quite quickly, and it being very targeted, very relevant. This reality that it ought to have testimonials and voices of people with lived experience throughout. We've tried to reflect those quotes, those reflections, as we've put the resource together. And finally, that it needs to contain a feedback element, an evaluative element. You know, how do we measure the impact of this? Where is it going? Who's using it? What sectors are using it? And we've tried to build that into it as well. And hopefully I'll kind of be able to illustrate that a bit later when we walk through the resource. So just to finish then, a couple of things about what the resource is and isn't. So it's designed to be a primer to support faith-informed conversations. It's designed to support general prevention conversations, not crisis presentations. It's meant to generally encourage faith and culturally aware approaches to suicide prevention. But what is it not? It's not a comprehensive guide to suicide prevention and postvention. There's a lot of resources out there. There's training out there. This isn't meant to replace that. It's meant to complement and sit alongside. Very much not a replacement for standard training in that way. And finally, and this is a really key point, we really want the resource to be a living document. This isn't something that's set in stone. We want it to be something that can be improved over time and added to. We're aware that as we launch it today and lots of you kind of have a look and a read through it, there may well be things that need to be changed, and we invite feedback on that. But we see this as something that isn't static, but can be improved. So that really draws my bit to a close. Looking forward to walking through the resource a bit later. But I'm very pleased to actually hand over now to our first panelists on this theme, and that's Safia Koka and Mariana Kovalenko. Safia is Senior Public Health Strategist for Mental Health within the Royal Borough of Kensington and Chelsea and Westminster City Council. And Mariana is Public Health Officer for Mental Health. And they've been really leading on the bi-borough's engagement work around suicide prevention in seldom heard communities. They've been really supportive to this work, and actually this program of work that we've been doing fits within the broader engagement that they've been carrying out. So I'm really pleased to hand over to Safia and Mariana to hear what you have to say. Thank you.
Thank you very much, Jeremy. And can I just say thank you so much to inviting us to this webinar to speak about the work that we've been doing with you, and to talk about some of the outcomes and findings that we have ascertained through our community engagement itself. So I think what's really important in terms of when we talk about suicide prevention and we talk about our communities itself, it's really how do we support our communities to be able to talk about suicide, to talk about self-harm, and to be able to support our sort of our residents, our communities, but as well as our frontline staff and caregivers around suicide, but use faith as a real prominent support pillar, and for people to feel that they can have this conversation and can come to their faith leaders and to open up these sensitive conversations, especially around supporting their friends, their families, but also if they're in crisis themselves. So what I would like to do is just talk around why are we here today? And in Westminster and in RBKC, we have a suicide prevention strategy that lasts over 3 years, and every 3 years it's refreshed. And in that strategy itself, we have 8 key priorities, and the key priority that we are going to be sort of focusing on, and this is the real foundation of why we're here today, is around how do we make our communities suicide safer and support our communities around this conversation. So as you can see, this conversation has been happening since 2020. But what we have ensured is that this has been a continuous conversation with our communities. And how do we sort of raise that profile in terms of having the conversations, making sure that our communities and our community leaders and our frontline services are comfortable in having these conversations, but also who can we sort of call to be able to support us through this journey. And I'd just like to sort of zoom in terms of November 2022, when we had our first initial engagement with our seldom heard communities. And what does seldom heard communities mean? It means those communities that are not their voices aren't strong enough, and we need to listen more and make sure that our services are there for them and they have access for them, and our services are equitable in terms of making sure that they are culturally open to the different conversations from the person that is accessing it. So from that engagement in November 2022, what was really loud and clear was there's a real key discussion around faith, around how faith can be a support pillar, but also how can faith sort of open up the doors to this conversation to support their communities, no matter what faith they belong to. And then the conversation opened up to around stigma and around how can we sort of break down the stigma relating to faith and suicide and what the scriptures are saying. So we knew from that point that there was a call for action to absolutely engage with our faith communities. And so then in April, we actually brought together across both borough our faith leaders, but also our residents and our communities who wanted to be part of this sort of resource, but also allow their voices to be heard, but also to be incorporated in terms of the resource itself. So what the key things that our seldom heard group said is that they wanted to be part of this sort of resource. They wanted to be heard, they wanted to co-produce, and they wanted to be part of the conversation and also express their lived experience. They also wanted to make sure that this resource was specifically targeted towards our faith groups, but also ensuring that there is training provided to support our faith communities in this conversation, but also identify what bereavement support there is within the particular faith groups that is culturally, open and accessible. But also to understand that we want to work with faith group to destigmatize access to support, but also let our faith let our faith places be safe for that conversation. So what I'm going to do now is hand over to Mariana, who's going to speak about some of the data, but from the journey onwards.
Thank you. I'll just take a step back and give you a quick overview of what we know so far in terms of data. So we do know that having suicidal thoughts is common, and 1 in 5 people would have suicidal thoughts on a yearly basis. And 1 in 14 people might experience self-harm. 1 in 15 people might attempt suicide. And then the most important thing is that each suicide results to 135 people exposed, from which 20 people could be severely exposed. And the people impacted by suicide are 65% more likely to attempt suicide themselves, with at least 9% going on to make a suicide attempt themselves. And around 8 people who are bereaved by suicide will drop out of work or education. Sophia mentioned previously that in April we've had an engagement with our faith communities, our faith leaders, and our residents with lived experience. And what we have done is we've asked 6 questions around what the resource would look and feel like, and also just to identify what are the trends, what is needed, and how we can further collaborate on this. So there are for me key main points. So with all the faiths, there was a level of misconceptions and myths around the suicide, and we've established that using scriptures could help break down the misconceptions and myths. With each faith, there's a protective factor of suicide, and there's an important relationship between the physical and the spiritual being. We've also recognized the LGBTQI plus communities and faith, as there's a lot of stigma around how communities see the LGBTQI plus community. And we've also established that there's a need of having a clear narrative and language to use to avoid stigma and discrimination around suicide and self-harm. Also during the workshop, we've identified that there's a need of having conversations around the high-risk groups and the causes of suicidal feelings. So we do know that men are the most impacted by suicide, but we also have the homeless population. We have people who are socially isolated. We have people in care of mental health services, children, young people, those who are impacted financially through loss of employment, with the impact of mental wellness, and also the LGBTQI plus community. And there are also multiple causes of suicidal feelings. It might be postpartum depression, it could be cultural pressure, it could be the end of relationship, isolation, or loneliness. And what we have done is we've looked at those high-risk groups and those key risk factors. And at Kensington and Chelsea and Westminster, we've developed the Stay With Us campaign. And the campaign has 3 elements: the web resource, which is a dedicated suicide prevention directory of services. We've also had a campaign toolkit and the training offer. So I'll just take a step back, and what I wanted to share is that we've included the faith resource on our web resource. So if I take a step back, you'll be able to see our directory of services. We've grouped all the services under different topics, and we've included the faith resource under the suicide prevention online resources, which is just here. And then also, as part of those 3 key elements, our campaign toolkit has all the social media assets and the narrative if people want to post on newsletter or do a reach out email. And we've also had the Making Every Contact Count for suicide prevention training, which gives you the framework on how to start those conversations around suicide. And then I'll ask Sophia to take over. Thank you.
So, as Jeremy mentioned right at the beginning, it's all about how do we upskill our communities. And as part of our Stay With Us campaign, we have 3 training offers. But what is really important about upskilling our communities itself is that we'll be asking Every Life Matters to be working with each one of our community leaders in RBKC in Westminster to make sure that there is a specific training around the different faiths that we have represented in our byborough. So again, it's around upskilling our faith communities. It's upskilling the communities that are part of these faith organisations, but as well as upskilling our frontline staff, so they are aware of the different conversations as around suicide prevention, but also that cultural awareness of how to speak and be much more aware of the facts around faith and suicide. So that could be part of the conversation as well. So I'll hand you back over to Jeremy, and thank you very much for your time today.
Thank you both. Really, really helpful presentation there. And I think just a really, clear illustration of how this conversation about faith can really touch down at that local authority level and create a real kind of practical impact there in terms of working with faith leaders locally. So thank you really for that. I'd love to hand over now to our final speaker today, and that's Dr. Imrana Siddiqui. Imrana is a GP in East London and clinical lead for mental health in Newham, and as well as that, she's a volunteer for British Islamic Medical Association. She speaks and advises on the interplay of faith within clinical practice, and Imrana was also a great help in the development of this resource, particularly from that perspective of the potential user group for the resource. So Imrana, over to you. Really looking forward to hearing what you have to share.
Thank you, Jeremy. So thank you for that warm introduction and inviting me to speak today. So let me just share my slide set, bear with me. Just checking that you can see that front screen. Jeremy, just say a yes if you can see it.
Yep, that's all good.
Perfect. Okay. So I thought I would talk through two aspects really in my talk today. So, and I've titled it Reflections from the Consulting Room because I wanted to bring in the stories of my patients and what I learned from them as well. So so two parts of what I wanted to talk about. One is why our faith-based approach is needed in suicide prevention, and this will just kind of build on what's already been said today. And then I wanted to share some reflections from my clinical work and from my patients. So going to that question of why is faith-based approaches needed in suicide prevention, again, my previous speakers have already mentioned this and the complexity around it, but I thought it's useful to divide it into kind of thinking of it in two different ways. So you're thinking about the individual person themselves. So I think from the individual point of view, if you go back to the real basics about suicide prevention, is, why do I want to live? Why do you want to live? And what faith can offer is, to some people, is clarity to these fundamental questions. So often people can find that faith gives them a sense of purpose. It can help them feel valued and give them a sense of belonging. And I think also that Jeremy touched on as well is that faith can give a unique lens through which people can understand suffering. And for example, within the Abrahamic faiths, there's the concept of life being a journey through which you travel. So it can be quite transformative for people and patients if they understand their suffering in this world as not the beginning and the end, but as a part of a journey and hopefully leading to the bigger picture, which is an eternal heavenly life. So in this sense, faith can be very important in building internal resilient and individual people and patients. And I think as our colleagues from the public health team have just very clearly illustrated how important it is in terms of the community side as well. So again, within our suicide prevention strategy within Newham, one of our key themes is building on community assets. So I think the fact that these faith communities are they're a huge community asset that we have. If you think about physically, they're embedded physically in spaces within our communities, and also it's a place where people gather and congregate, and as described before, is a place where people can get a lot of support from each other. So I think there's that two ways that it can be quite helpful to think about faith within suicide prevention. So for the rest of my talk, I wanted to just, share some reflections from my consulting room. So perhaps I'll give you a little bit of context. So I work, as mentioned, in Newham. For people who don't know, Newham is a borough in inner East London, and it's got a high level of deprivation with, however you score deprivation, and it's hugely ethnically diverse area, and In fact, it's the most ethnically diverse borough within the United Kingdom, with I think around 100 different first languages being spoken. So that's the context of where I work. And I just wanted to share a few things. So patients often either during the consultation or usually towards the end of a consultation, quite commonly patients ask me to say, when they're leaving, doctor, can you pray for me? Or, pray for me, doc. And this is in the context of without me even discussing or talking about faith during the consultation. And I was thinking about this, and I thought I can't remember going through an entire clinic without somebody having said this to me or asked this from me. And actually, I was in clinic all day yesterday, morning and afternoon, and my last patient who left, again on the way out said, "Doctor, can you pray for me?" And then I thought, oh, I'm doing this talk tomorrow. I should have counted how many patients have said that in the day. And then I went back just to think, and there were at least 4 people who had said that to me in just in yesterday, in that one day of 2 clinics. So again, I just thought I'd reflect on a few things about just that statement. One is that for some people, prayer is an important part of their health, their healing, and their treatment. And I guess the other thing, which is I think important to kind of acknowledge, is that, for example, faith or spirituality in the context of healthcare is not something that's taught at all in medical school, and definitely, obviously, I went to medical school quite a few years ago, and it wasn't something at all that was even mentioned. And interestingly, more recently, studies have shown that in a consultation, doctors don't bring up faith because they're waiting for the patient to bring it up if it's important to them, but patients are waiting for a cue from the clinician to bring it up. So what this can lead to is this kind of barrier within the consultations where the the patient feels unable to speak about what's important to them. And again, I was reflecting on this. So why do people ask me when I've asked this question to other colleagues and they don't get this comment as well? So I was just thinking, perhaps because I wear the hijab, people make the assumption, rightly or wrongly, that this is their non-verbal cue, their non-verbal permission to discuss faith within the consultation. So the other thing I think Jeremy also mentioned, so when we're doing a consultation, within that we would do a risk assessment, a suicide risk assessment, which or can be called a safety planning. And within that, we ask about protective factors for patients, and faith comes up really commonly in answering that question. So really, as a GP and as a clinician, it seems like a no-brainer that we're talking about faith in suicide prevention, because it's something which in real life is a protective factor for many of our patients. So what I thought I'd do is just share 2 anonymized patient snippets really of 2 patients of mine. So one is this lovely lady, Ana Santos, a 50-year-old lady from Portugal who's Christian. She's a long-term patient of mine. I've known her for about, I think, 13 years now. Complex mental health, physical health, and social issues. She suffers with chronic fatigue. She suffers with anxiety and depression, complex PTSD, is lonely, has got complex social issues, and with many people, unfortunately, in the place that I live, housing is a big issue. So she lives in social housing, has got kind of antisocial neighbours with antisocial behaviour. And so, again, just for a little bit of detail, so this lady has neighbours who play loud thumping music every single night for the last 10 years. So for 10 years, this lady hasn't had a good night's sleep because of the noise and her pain. So just thinking about adding that on top of all the complexity that she's living with. So as you can imagine, when she presents to me, she's often feeling quite hopeless. And sometimes during these dark, during these moments, she feels that she's at her rock bottom, and she tells me that she finds prayer helpful for her in the darkest moments. And despite feeling hopeless, and sometimes she will tell me that I don't want to go on, I wish I wasn't here, but she would never consider suicide, as from her understanding is that this is God's chosen life for her. And another patient I just wanted to share, again, it's a patient I saw last week, again, anonymized. His, name is John Taylor. He's a middle-aged Englishman, and he was recently released from prison. So basically, over the last 10 years, he's been in and out of prison, mostly in prison over the last 10 years. And while he was in prison, he had mental health issues and was on medications. And according to the patient, when he was released from prison a few months ago, rather, he was released without any medication. So his mental health deteriorated. He became in a really dark place. And luckily, a family member kind of encouraged him to seek help and to see us at the clinic. So I saw him, last week, and we were kind of dealing with his mental health issues and trying to get him back on his medication, titrating his medication, and also supporting him to reintegrate into life as a free man. And again, as part of this, risk assessment, I was asking him about kind of thoughts of suicide, and particularly as I was titrating his medication. And then he said to me, no, doc, I would never consider this. I'm a Muslim. And then he went on to explain that kind of his mother was a Muslim Turkish lady, and his father was British Christian, but and he had always been kind of in his younger life pretty ambivalent about faith. And he described it in his own words that he said, I had lost my way, but now he felt more observant with his faith, and that was protective for him in terms of kind of harming himself. So I just thought I'd leave. I'd finish my presentation with just sharing a few, I guess, top tips from my point of view. So one is, this is mainly for the clinicians who are out there in the audience today. We can often compartmentalize patients into organ systems. So if you've got a heart issue, you see a cardiologist, and you don't feel that you've got the permission to talk about anything else in your life. But just to remember that patients aren't the sum of their organs. And again, even within our health systems, if you've got a physical health problem, you see one person. If you've got mental health problems, you see a different service. If it's a social issue, you go see somebody else. And if it's spiritual, then it's kind of definitely not within our remit. So patients again and again have said to me that they want to be seen, they want to be heard as a whole person. So it's just my kind of plea that kind of, we're not going to be able to fix everything in people's lives, but I think the importance of having that safe space that they can share that what's important to them. And again, as I mentioned earlier, the research has shown that the patients are waiting for that cue from the clinician to be able to bring in what's important to them, and for many people that includes faith. So I think this this resource which is being launched today, I think is really helpful, particularly in this, because this resource guides you as to how to do this in a way which is sensitive, and it will give you confidence in doing so. The other thing, again, I think has been touched on before, is just that importance of personalized care. So even if you see different people, two people maybe from the same background, look the same, but again, don't make assumptions about that person. Ask them what's important to you as an individual. And also, I guess my last point is that, again, illustrated by the second patient I talked about, is that patients' life journeys are individual and very different. And faith can be important to somebody in varying degrees throughout their life. And I think that's it from me. I hope those reflections have been useful, and again, happy to take questions later on. Thank you for listening.
Thank you so much, Imrana. That was so interesting and helpful. Really appreciated those reflections from your experience in that clinical setting. And surprising as well in terms of hearing that reflection of how many people ask you to pray. I think that's just really helpful to know that it really is a part of what people see as important in that setting. Great. Well, I'm aware that we have had a few questions come in during the presentations. Do continue to post questions if you have something that you want answered. But Peter has been behind the scenes, kind of gathering in those questions and identifying which ones we want to ask. So, Peter, is there a question that we could maybe kick off with, either for myself or for the panel, in terms of getting that answered?
Hi, yes. So we'll start with one question here. So will there be future work focused on the other points you looked at? So that was to you, Jeremy, on upskilling faith communities and theological engagement around stigma and misunderstanding. They would love to know if and when will this be explored?
Great. Yeah, good question. I suppose that's asking about, I think I talked about that need to engage with faith and doing a faith-facing piece of work. I think my answer to that question would be, we would love to be able to move into those spaces and do that work, but we are always limited by capacity and resource in doing that. We have a relatively small team, and the reality of the situation is it does depend on boring things like funding and capacity to be able to do that rich engagement work that would be needed. So I suppose the simple answer would be we'd like to, but we're kind of exploring how and when that might be possible, in terms of thinking about our future work. So hopefully that answers the question a little bit.
Great stuff. I believe this is geared towards Imrana, particularly about the point on about professionals and praying. So we've had some points saying, is it okay for a professional to pray with patients, and whether the culture has changed significantly because previously they've lived through eras where GPs were censored around praying with patients. So what's your insight on that, and where has the culture led to now?
Thank you. That's a brilliant question, and it's actually a conundrum I'm always thinking about, because as I've described, it's quite a common scenario for patients to ask me to pray for them. So how I think about it is that firstly, the fact that they've asked you or have asked me, I think that to me that kind of illustrates that I've allowed that psychological safe space within the consultation where they feel that they can talk about what's important to them. But again, this is, as I've said, in medical training, it was actually, not only were we not taught how to talk about faith within our consultations and within healthcare, I think the only thing we were taught is that, you don't bring it, you don't discuss it. So, and I'm very, very aware that there was there have been cases, and I think the most recent one, there was a Christian GP, again, I don't know all the details, who prayed for his patient, and he was referred to GMC, and that led to a suspension. So, I'm very aware of that. And again, again, speaking very transparently, I'm, kind of GMC referrals are disproportionate, towards doctors of ethnic minorities. So we do feel vulnerable in that. Actually, where is the line to draw? So I think I guess my answer to that, there hasn't been a change in guidance, and I think the key thing is about again having that kind of psychological safe space where it's a non-judgmental space. You don't you allow the patient to bring it into the conversation, but the key is that this resource will help you as to kind of how to frame that question, how to bring that into the conversation. So rather than you imposing yourself or saying anything in particular about that, it's allowing the patient to bring what's important for them into the consultation. So I'm aware that that's not kind of a hardcore, yes or no answer, but I think there are lots of nuances around this in particular, which I think are important to kind of think about in terms of when we're, how we design health services. But this is again just to say that this is a way of allowing the patient to bring what's important to them.
Thank you very much. Hopefully that's answered the questions to those that asked it. Across the panel, so there's a question here, or a statement rather. So just want to try to get your thoughts on this. So faith can be protective, but occasionally I have come across it being exacerbation, sometimes due to poor understanding of the person by others or poor understanding of the faith by the individual. So, I mean, Imran, have you come across, maybe not in your own work, but maybe with different faiths, how to navigate patients of different faiths to you? And yeah, how's that been, if you've had that any sort of experience or any insight into that?
Sorry, Peter. So the question was how to navigate when there's patients of a variety of different faiths. Is that right? And how to was that the question?
Well, yeah, because the person didn't put full question, they just expressed their experiences of it being sometimes protective or sometimes an exacerbation due to poor understanding of the faith or other people misunderstanding the person or the faith. Do you have any insights onto different understandings of different faiths and how that contributes to the treatment of the person?
Yeah, so I think again that's a really good point, is that and I think kind of Jeremy put that as one of the things to look into. There's a kind of theological aspect of, you know, what does a faith say about certain things. And so for example, from an Islamic point of view, you know, there's no stigma about mental health, and there's lots of examples within prophetic, you know, sayings and life experiences about the importance of looking after your mental health, and it's not a sign of, you know, weak faith. But in a cultural context, particularly within the South Asian communities, where a lot of the Muslim community in Britain come from, there is this some of the stigma, taboo, the negative connotations come from that kind of cultural understanding of faith rather than from the actual pure, you know, theological understanding. So there is that kind of complexity and nuance, which is really important, and I think we need to be aware of, because when we're trying to tackle these issues within the communities, we need to just understand those differences and, I guess, enable other people to, you know, to have that understanding about the cultural aspects as well, and the difference within the actual true teachings of, you know, the faith and the religions.
Stuff. So across the panel, specifically for Safia and Mariana, so the people reported that the language that some GPs use around self-harm and attempts is not helpful. Safia, could you expand on like maybe your experiences on that, and Imran, if you've had any insights into GPs trying to navigate with suicide and self-harm and attempts, and whether if you had some space to collaborate with between public health and GP and really had the space to support each other through this work?
So through the consultation that we've had with our faith communities as well as our seldom heard groups, one of the challenges that was raised was when a person who's in crisis enters their sort of a setting such as an A&E or their GP, the language or the assumption sometimes is not helpful. This is what's really sort of broken down sort of the relationship between the individual and their GP, or if they're in A&E, the doctor or the physician that's seeing them. So there is a piece of work around language, but as we understand is that people or professionals who aren't of a particular faith sometimes feels ill-equipped to be able to support someone of another faith. So, and I think this is the value of this resource. And as Jeremy says, it's a live resource, so it will adapt and it will move and it will change, and it will be updated. Because I think what's really important about this resource, it sort of broadens the understanding of what different faith sees and thinks about mental well-being, mental health and suicide. As Imrana highlighted, is that there is stigma within communities around mental health. People don't speak about it, but also in terms of the languages that people that go to a physician and it's, do they tell the full story? Do they tell the full picture? Because of the stigma that's literally culturally around it. So therefore being signposted or supported with the right help can be a challenge itself. So we understand that there is a challenge around communication, around the narrative, around the language, but also that understanding. And I think this is where training is really important, to open up that conversation about suicide, self-harm, but also understand that there's nothing to be afraid of, and using this language as it is in the true form is it's okay to do so. So we understand that this is a challenge. We understand this is a journey, but the more people that are upskilled, the easier, hopefully, things will become.
Peter, would you like me to come in as well?
Yes, please, before we move on to our presentation.
Yeah, so thanks for that question again. Again, from a GP perspective, as you all know, we are we are very time pressured, and sometimes that can come across as being kind of perhaps abrupt or not open enough to listening. But again, that should not be an excuse at all. I think there are a few kind of different things, I think, which impact on that relationship and how approachable the GP is in terms of talking about suicide and the language that's used. One is, I think there's a kind of a historical context in the sense that perhaps even 10 years ago, if you came to your GP and said I feel suicidal, that would automatically mean you can be referred to the community mental health team and they would take over. Whereas now we know there's been kind of almost an epidemic of self-harm in particularly in the youth, where the mental health system is obviously overwhelmed, and there's a lot more kind of risk and complexity which needs to be held within primary care. And so I think there is that element of perhaps just overall kind of understanding, confidence about talking about suicide and self-harm within the primary care professions, including GPs, is something that I think needs to be addressed. And again, that faith aspect again is a thing that, again, as I've said, is something that has not been taught in medical school. And again, I think this is where this resource is really helpful in terms of kind of giving you that kind of confidence to be able to have those confident conversations. And just to pull on to something that was I think put in the questions as well, which is a really good concept. So we've got NHS chaplains within our secondary care services, which provide a valuable resource for spiritual care for our patients. But we don't have something like that for primary care. And the question is, why not? We're holding a lot of this complexity, we're having a lot of these discussions here, and I think that's it's a brilliant suggestion that we can have that. So rather than kind of it falling onto the GP or the practice nurse when you're doing the smear, you've got more people in your team with that expertise of spiritual care.
Great, thank you, Peter, for fielding those questions. That really interesting reflections there. And we will have a little bit of time, I hope, at the end for any more questions, but I'm conscious that we want to get to introducing the resource itself and navigating through that, and that may throw up some questions in itself. So without further ado, let's move on to that part of the webinar. And this is also the part of the morning with the maximum opportunity for technical failure, which always adds a degree of excitement. So let's see how we do. But I'm just going to share my screen and hopefully lead us through the resource. So bear with me. Just close that window. You should see on your screens now a web browser with the resource. Is that all good? Someone give me a thumbs up. Can we see that? Brilliant. So what you're looking at the moment is the home page for the resource, and it's important to know that whilst this resource, it does have general content about faith and suicide prevention. A key part of the resource is that tailored specific content on 6 particular faiths, and obviously there are many faiths present in the UK, but given the time that we had to limit ourselves somewhere, and so we did limit to 6 faiths for this particular project. But you can see that this main navigation bar runs across the top. But we also wanted to make these faith pages as accessible as possible, and again, bearing in mind that need for it to be at the click of a button, as quickly being able to access that key information as possible. So the 3 clear sections really in terms of navigating the resource are these ones that you see here across the top. So the why, the what, and the how. So that's why are faith-informed conversations needed? What should I be aware of when it comes to faith and suicide prevention? That's where the particular faith pages sit. And then finally, how do I go about addressing faith within holistic conversation. I think that's the bit that Imrana picked up on a little bit there at the end in terms of those practical suggestions. If you're in that setting, if you're having a conversation with a member of the public, what are some of the things, what are some of the cues and ways that you can bring faith into that conversation in a very natural, non-threatening way? Another thing to point out is we have this key organizations and resources section of the resource, and that's a page in itself that you can access here. These resources, so these organizations and resources, will be included throughout the resource, so in the specific faith sections and other pages within the resource. But we wanted to have a kind of one-stop shop where they're all visible, just so you can access those nice and easily. The thing that I'd like to mention about this, and I've touched on this already, is that we do see this as a living document. We're aware that there will be links and resources that need to be added to this. There'll be ways in which this resource can be improved. But we really do want to invite all of you who kind of log on and have a read of the content after we've launched it today to get in touch with us and give us feedback on the resource. And actually, we wanted to make that a part of the user journey through the resource. We've got this little dialog box here. You can see in the corner a sort of little speech bubble. If you click on that, it gives you just a very short survey, which allows you to input just some key information about where you're coming from, why you're using the resource. And that really will just help us gather a little bit of data about where it's going, where you're based, how did you hear about the resource, and just help us improve it and make it more accessible and all of that. So do use that. If you get a chance to look at this resource a bit later on today, have a bit of a read, explore it, and then just let us know what you think, because that will only make it stronger. So what I want to jump into now is just going through some of the content of the resource, and really the bulk of the qualitative content that we put into this resource that came from our engagement around faith and suicide prevention can be found here in this what section. What should I be aware of? And particularly this 8 themes on faith and suicide prevention. So I'll just navigate through to that. So when we did our workshops, when we did our engagement exercises, these were the sort of themes that really came through out of that. We sort of summarized those. And as with the whole resource, we've tried to kind of use this button-based navigation just to make it as simple as possible to kind of navigate through that content. So you can read it just through scrolling, but you can also access those buttons and jump through the content if you need to see something more quickly. But really with these 8 themes, these are things that came through that were seen as protective or positive elements of that faith engagement, that faith context, but could also present challenges. And so for each of these areas where we've kind of included this information, we've tried to reflect that dual aspect and also include quotes, reflections from people that kind of tie in with those particular themes. So just again, an example here around bereavement and burial practices. We heard that faith communities have many different beliefs and practices around death, bereavement, and burial, and that these end-of-life rituals can really help families deal with loss and find meaning and comfort in difficult times. However, there can be challenges accompanying these practices. For example, in some cases, people who die by suicide can be excluded from traditional burial and bereavement practices, and historically that was more of a case. But also there can be generational differences around theology and practice, and sometimes there can be a sense of this over-reliance on tradition can mask the reality of someone's suffering. So both that positive and that negative element again coming through, and that's the case with all of those sections. Just moving through to the how, just dipping into that briefly as well. How can I go about addressing faith within holistic conversations? Again, as Imrana sort of said, this is the part of the resource that really gives some practical tips around how you might want to bring faith into those conversations, whether that's including standard questions about faith and belief, with some example questions, letting people lead. Again, re-emphasizing that need for cultural humility. So do take a look at that in terms of those practical suggestions, those practical tips of what you can do. And I just want to finish really by circling back to the homepage and really just taking a look at the faith-specific pages and diving into what we've included here. And these were developed in partnership with different organizations working within the faith sector, with faith leaders. But we also do acknowledge that there will be limitations to these, and we're very much aware that when we think about particular faith positions, there is no one single Christian position on these things. There's a huge variety of denominations and theologies within faith traditions, and we want to reflect that. But this is really just about giving a very brief summary of some of the kinds of things that Christians may believe and how that may impact the way that they're viewing the world. And so we start off with some key quotes from Scripture that may be of relevance. And then we move into the main navigation, which is snapshot, support, and additional content. The snapshot is really about just giving some top lines around how life, suffering, and death may be understood within different faith positions. So as you can see here, this is the kind of particular Christian lens. But as we move through to support, we're really interested in that question of when might a person of faith who is a Christian, when and where might they seek support? If they're experiencing difficulty in their life, where might they go to for support? And so that's reflected in when do Christians gather and connect? Where do they gather and connect? The diversity of practice there. And if a Christian wanted to access faith-based wellbeing support, how and where might they do this? So again, just some kind of key content on that. And finally, we get to, are there dedicated organizations offering faith-informed support for the Christian faith? And this is where we've tried to gather together the different resources and organizations that we found that provide support for that single faith focus. And so you can see here we've got a suite of case studies that's available online, the Mental Health Access Pack. We've got some courses that are available looking at mental health and suicide prevention, and we have a helpline there specifically for a Christian audience. And then finally, additional content. This is really content that came out of our discussions and was supplied by the people that were supporting us in this resource that didn't really fit in any of the other areas, but is still of importance and kind of helps build that picture from a single faith perspective. So again, we've got case studies and testimonials here, and we have some particular content looking at the church and stigma throughout history and how that might affect views on suicide. So that's really the goal. And each of the faith pages follow the same format. So if we quickly look at the page for Islam, again, we've got the quotes there, we've got the snapshot, support, and additional content. And there really is some great resources, some great links within these pages. So do take a look, do have a read. And as always, let us know what you think. Let us know if there's anything missing, because I'm sure there is a lot missing. We do want to keep updating and improving this resource. So there we go. That's a very brief overview of the resource. There is obviously a lot more that could be mentioned, but I think this will really come into its own when all of you are able to go away and just have a look at it and navigate through it and have a read yourself, and of course ask questions of us. So I will finish sharing my screen there. But I did just want to allow a bit of time as we get to the end to see if there are any further questions that anybody may have, either to me about this resource or again to any of our panelists. So Peter, were there any final questions that people had as we draw to a close?
Yes, we do have a couple of questions here. I think we can go to, we can address this to Imran actually. So do GP services look at employing chaplains who could help with religious or spiritual care for patients, as this will bring in expertise and safeguard GPs?
Yeah, so I think I touched on that. I think, I think it's a brilliant idea. And actually, I think in the chat, I think that everyone can't see, but somebody has shared an example of a chaplaincy service within general practice in South Yorkshire. So I think it's a brilliant idea that actually, again, it shows a bit of the kind of inequality between what secondary care get and what primary care get in terms of wider professionals within the within the team. So I think it's a brilliant idea. But again, the only kind of caveat I want to also add is that, again, the patients keep telling me that they don't want to be they want to be considered as a whole. So, you know, it's, you know, we don't want to say, oh, this is a spiritual issue, go speak to somebody else. If this is important to you in terms of important in your treatment and healing, then I want to know about it, and I want to include that in my kind of holistic, personalized care plan that we make together. So just kind of including that caveat, but overall, I think it's a fantastic idea to think about.
Thank you very much. We've got another question here. This is open up one. So, basically on your experiences on dealing with these sensitive situations and with faith, but this is particularly sensitive in terms of where faith suggests that a person may go to hell based if they take their own life. So the person says that they're pleased to hear from the speakers, but they're curious to know how to manage the situation of when you're communicating that faith seems to imply that the person will go to hell once they take their own life. And they're just unaware of whether this is the case for other faiths. The resource does address this sort of issue. They do touch on this issue across all the faiths that we've put on the resource as well. We made a point of that on the resource. But across the panel, do you have any experiences on that? Do you have any insights on touching on these sensitive topics?
I'm happy just to jump in, Peter, quickly from my perspective, and then see if any of the other panel have thoughts on that. But only just to say really that obviously this is a very kind of complex area and sensitive area, but it was something that came up in our engagement. And as Peter said, we have included that within the resource. And I think there was reflection really that, as I said before, you know, different faith traditions are not homogenous, and there's such a variety of theological approaches. And actually, many of these views around suicide are kind of quite historic positions that were taken by faith communities, where there may have been sort of theological development or changes in how faith communities view suicide. And there's been a lot of theological work in recent years thinking about that and looking into that. So we want to reflect that, whilst also recognizing that this is part of people's lived experience, and it might be something they feel as they're going through those situations. I don't think it should be the responsibility of the frontline professional to dive into those issues, because that isn't their expertise. But hopefully within the resource, there are enough links and suggestions of places people can go to find up-to-date perspectives on these things, and continue that conversation and get further support if that's a particular concern for people. That's just my reflection.
I'm happy to jump in as well if you. Oh no, go on, Sophia. I think I've hogged the mic a lot today.
No. I just think that it's around those conversations and understanding that if we want to take a community approach and allow us as residents and community leaders to be able to have open conversations, is also managing those expectations. We are not medical experts, we're not clinical, but what we are able to do is to provide a listening ear, allow a conversation, and allow that person to express themselves. But I think, as Jeremy, you've highlighted, the resources there to be able to inform us and guide us, but to support us, to bring that confidence, to be able to have a conversation and the awareness of different faiths. And I think that's really important, is that, you know, I'm not a clinical person, but I am able to have a conversation, and sometimes that is what is needed, someone to be heard, a conversation is to be had, but also that person being able to be supported in what those next steps are.
Yes, please go ahead, Marina.
Thank you. Can I just jump in? So I wanted to add something around the Making Every Contact Count training, which emphasizes something that the faith resource emphasizes as well, and it's about being curious and having those conversations. And also the faith resource mentions that how can we bring the focus on the protective factors more than just having conversations around how faith might have a negative impact. So it's bringing the person to the positive factors.
Thank you very much, everyone. Any final questions before we wrap it up? Feel free to put it in before we finish, just conscious of time.
There was, Peter, there was just a question about will the slides be shared? We can share the slides for today. Certainly from our side, I can't speak for the other presenters, but yeah, any slides that have to be shared, we will circulate to attendees. So yeah.
Yeah, so after this, I will be sharing the slides and the recording once it's ready. Yeah, to everyone that's basically signed up and everyone that's on this webinar.
Great. I think we'll probably draw things to a close there, Peter. But thank you again for taking us through those questions. It's been a really interesting webinar. Before I hand back to Daniel to close, just to say we will be making the resource live following this, so look out for that link and do please have a read of it. Otherwise, over to you, Daniel, and thank you again to all of our panelists.
I don't think anybody gets the Faith Action mug for muting themselves. I think we did all right on that. So well done to everyone. There was a slight moment I thought I was going to fulfill that promise myself. But anyway, it leaves to me to thank everyone for coming today and to listening and contributing. Appreciate the questions, the points there. As Jeremy said, there are obviously those the little survey within the resource as well. So it'll be good to just kind of hear how people are using it, where they've come from, so we can look to gather information and thoughts. There'll be a live link to resource will be hitting your inboxes shortly if all goes well. If there are any problems, do email us at info@faithaction.net and we'll see what's gone wrong there. Thank you to the panelists. Thank you very much. Really rich reflections and discussion. And let's keep the conversation going. Let's take a look at the resource. Let us know what you think. And do take a look at the Faith Action website. Have a look at the health and areas so you can see the other work we're doing and engage with at the moment. There may be points of interest and points of connection in that sense. So thank you very much for coming, and looks like we're ready for lunch.